Welcome to Context for Healthcare's Fireside Chat. Our topic is the billing of the highest level of definitive drug testing codes in a family group of procedures where that highest level service is not appropriate. We'll show you how to find this in your claims data. We'll use an example, real life example from the field, and we'll provide you with some guidance you can take home to use with your analysis. I'm Steve Nesnidal. I'm an MD, Medical Director of the Vice President of Compliance of Context for Healthcare. I'm an MD with experience as an attending in emergency medicine. I'm a CPC with managerial experience in a pro-fee billing service, including clinical pathology, and I am an NHCAA accredited healthcare fraud investigator. Context for Healthcare, we're 30 minutes west of Chicago in Naperville, Illinois. We've got over 30 years of developing payment integrity solutions. We also offer reference-based pricing and UCR fee schedules. And we're an AMA partner, so we can serve as your source for healthcare master data. And this slide is an overview of the drug testing codes. The presumptive screening codes are at the top. They're CPT codes 80305, 6, and 7. The CPT code selection here is based on the method used to read the test. And on the bottom are the definitive drug testing HCPCS codes that most payers, including CMS, require for reporting definitive drug testing. In order to determine which G code to use here, it's based on the number of drug classes tested. This slide shows the presumptive drug tests and their 2023 CMS clinical lab fee schedule reimbursement amounts. The fees aren't high. The tests, there's a rapid turnaround for these tests. So providers that need quick data to make clinical decision making get this data quickly. But it's limited in that the precision of the results often aren't satisfying certain clinical needs. Next slide. This slide shows the 4 definitive drug testing G codes and their 2023 C-Lab reimbursement amounts. The reimbursement amounts are higher for these. These tests are performed on machines like mass spectrometers, gas and liquid chromatography, and sometimes it takes multiple of these machines to complete these tests. The G code requires whatever machines necessary to definitively determine if the compound is present and then report the concentration of that compound in nanograms per milliliter. Mass spectrometers are machines that are kind of like a weighing scale for molecules. You inject a sample into these machines, they heat the compound, ionize the compound, and send the compound through a magnetic field, propelling it onto a detector, which it's a pattern basically in the detector that identifies the compound. As I mentioned, these codes are based on the number of drug classes tested, and this has been an issue, a coding problem for a while. So in the next slide, I'd like to elaborate on what is a definitive drug class. Drugs in the same, first up, drug classes are determined by the FDA. Drugs within this same class basically share significant scientific properties. Either they share a mechanism of action or a physiologic effect, and or they have a similar chemical structure. So I'd like to take as an example This is a list of a few definitive drug classes and some of the common drugs and metabolites that belong to each of these classes. So if a provider needed to definitively test for methamphetamines, a street drug methamphetamine, regardless of whether they just needed information about meth or if they also needed information about a few of its metabolites, like amphetamine or norepinephrine. For the purposes of this G code, whether it's one or multiple of these compounds, that counts as one class. Drug testing has been the subject of 2 different OIG audits in the last 4 years. There was one back in June of 2021. The topic of that was just all urine drug testing codes. And the OIG saw several concerning patterns at that time. This year, in February, they reported a second audit, and it was focused specifically on the one highest drug testing code, definitive drug testing code, G0483. OIG isolated a group of aberrant providers that were submitting this code at a significantly higher level than the other providers. And they estimated that Medicare overpaid over $215 million in the 5-year audit period for this code alone. They also mentioned that there was a significant problem in overcoding regarding the G codes and the drug classes. So our takeaways from this is aberrant providers continue to submit this code G0483 at a problem rate. We also believe that to determine if G0483 was supported or whether it was instead a result of overcoding or fraud, we need to audit and we need to review the supporting orders. We took a sample of client claims and we used one of our FWA reports, our provider high volume claims report, and we focused on a year's period of time between last year September and this year September. And you can see a summary of our report. We've wiped out the provider names and truncated the MPIs to just 2 digits. But on this first report, in this sample, we found that the number 1 submitter of this highest level definitive drug testing code was provider number 27. They performed 70 of these over the course of a year. So what we then did, we wanted to see how this particular provider stacked up to the other providers in the same group. So we ran another report. If you can flip that. This is another report where we looked at all 4 of the definitive drug testing codes. So this lists the top 10 providers in the same sample, in the same interval of time. It shows our provider, our number 1 provider of the highest level definitive code is only the number 7 provider for all the definitive drug testing combined. So this provider was in a group where 6 other providers submitted more definitive tests than they did, including the number 1 ranked total definitive drug reporter that submitted 6 times as many definitive drug tests. Provider number 27 submitted 70 out of 84 definitive drug tests with the highest level code. It's over 80%. So we recommended to our client that this provider be audited for both orders and medical records. This slide shows a few points about what we recommend about the audit approach. First off, in reviewing these orders, definitive drug testing codes should not be routine standard orders. These things should be tailored based on the client's presentation and risk profile. So you need to watch out that a provider isn't just routinely ordering the highest level definitive drug test. The next thing, and I've mentioned it, we need to watch the order. These things are being ordered by providers mostly in addiction, substance abuse disorder patients' clinics, or chronic opioid pain patients and pain clinics. And so you need to watch how the order translates across to the labs who are performing these procedures. Watch to make sure there isn't an issue with classes. As far as the medical records, I don't have a lot of time, but I would like to separate out 3 different clinical scenarios that you will be testing that relate to this code. The first group are symptomatic, ill, overdose patients, altered mental status patients. These patients hit ERs, often get admitted to ICU. The definitive drug testing codes are going to be higher in this population. Toxicologists tend to check all the boxes or many of the boxes in these cases. So I'd like to contrast these sick inpatients with the other 2 bullet points on the slide. The other 2 are outpatients. They're stable patients. They're either substance use disorder patients that are being treated by addiction specialists, or they're pain clinic patients who are being treated for chronic opioid disorder by anesthesiologists and other pain specialists. Can you flip to the next slide? This slide just lists a couple of examples. When I look into the medical record, reasonable support for a definitive drug screen. Did they do a presumptive screen? And are they looking for a substance that presumptive screen doesn't test for? Did they get a presumptive test? And did they have a positive or negative result? And it didn't match with the patient's clinical presentation or the controlled substances that the patient's on. And then, if the provider documents they need to rule out a presumptive urine drug test error, those are just 3 examples. Many ways to do this, but tailored results, not routine standing orders. Information in the medical record that explains why a definitive drug test needs to be done, followed by a focal definitive drug test. I don't have a lot of time. This is pretty much my last slide. We recommend that all health plans establish their own drug testing policy that suits their plan. Some of the things that your plan needs to consider when developing your own drug testing policy: do you require a presumptive test to be done before you can do a definitive test? If you do, are there any exceptions to that? Do you allow a presumptive and a definitive test on the same date of service? And then another way that a lot of plans limit these codes: do you have utilization limits for this code? And then finally, we talked about, be clear as far as definitive testing, which codes you demand. If they're the G codes, be very clear about the basis of those codes is the classes of drugs. That's pretty much all I have time for. If there's an SIU out there who wants to come over to our booth, we're at 601 over here. I'd love to talk more about the identification process, the audit process. If you're a plan, you don't have a policy, you want to talk to me about that, I'll be in and out of some of these educational meetings, but if I'm not there, I'll be over here, so please come find me. And if you do want a copy of the deck, either come to our booth and give us a business card, or just give us a business email and we'll send one to you. So thanks for attending our fireside chat. I appreciate it a lot.